Hello, everyone, and welcome to another webinar from Diagnostic Solutions Laboratory. Today's webinar is titled Leaky Gut and Co-occurring Infections, Sequencing Treatment for Optimal Outcomes, and is hosted by Dr. Dan Kalish. Dan Kalish, IFMCP, is founder of the Kalish Institute, an online practice implementation training program dedicated to building integrative and functional medicine practices through clinical and business courses.
Okay, so welcome everybody. Dan Kalish here, and we're going to talk today about managing leaky gut and co-occurring infections. It's kind of complicated, but sequencing treatment options for optimal outcomes. That's kind of the theme. And I guess the big questions are always, should I treat this? What should I treat? What should I treat first? Do I do the leaky gut repair program before I treat the cryptosporidium, or do I treat the cryptosporidium first? Do I do them both together? Do I get rid of the gut bugs and then heal the gut? Do I try to heal the gut and then get rid of the gut bugs? Do I even need to treat the blastocystis? I have a patient came in last year, had a lab, had blastocystis on the lab, and the other practitioner just never treated him for it. So I was like, well, that's interesting. Maybe we should just talk about, should you treat these things even? And I'll give you a little history too about, how I came to all these conclusions. And let's see. Oh, here's me, Kalish Institute, done a lot of stuff. Like to talk about these labs, and a little bit about the history too. So, in 1992. I started to get interested in this work, maybe a little bit before that. I was actually a patient first. So in the 80s, I was a patient. In the 90s, I started to get interested in this stuff. And one of my early teachers that came around in the early 1990s was a man that some of you may know if you're old enough, Dr. Bill Timmons. And Timmons was focused on GI infections. That was really one of his big things. And I spent about almost 7 years, 6 or 7 years studying with Dr. Timmons. And so a lot of the work that I do now is based on what he taught me almost 30 years ago. And pretty much everything that we're going to talk about today is what Dr. Timmons taught me. And I've stuck with his protocols and programs because they work so well. I mean, honestly, I haven't changed like any of the GI things that he taught me, even a little bit. Which is funny because, for a lot of the other work that I do, things change all the time, right? You have new supplements coming out, new lab results coming out, new everything coming out all the time. But I guess, this is sort of time-tested, naturopathic, road-tested, battle-tested stuff that Timmons knew inside and out 30, 40 years ago, and I've been now doing for 30 years. So I guess this goes back, quite a couple of generations. And I think what I wanted to try to do today is a little ambitious, but is to describe the whole process by which we do this and lay out what I know are all the really common questions that I hear about from students in my mentorship class, okay? And we have some slides to go through, but also I want to make sure that you get some lab examples we'll look at, and then some program design examples so you can see how this stuff works logistically, okay? And hopefully this will save you a lot of time in terms of figuring this stuff out on your own. So, now, learning objectives, how to time the leaky gut repair programs in cases with multiple areas of gut dysfunction, how stress and diet can be the precursors to these problems, and then how to treat and repair leaky gut. So I guess the first thing to say right off the bat is that this really all comes down to program design skills. I mean, we're all looking at the same labs, right? It's not like your GI map test is different than my GI map test, right? The lab work is all the same. So the information coming in is the same. And I think where someone like Dr. Timmons, his skills were so refined was in program design. And again, I didn't make any of this stuff up. I just learned this 30 years ago from an expert and then figured out that it works really well and have never really had a need to change it much. Because it had already been worked out. So just passing on this information to the generations, really. So designing supplement programs that people will do and that are going to work That's a big part of this as well, is negotiating with the patient what's realistic, and then figuring out how to prescribe supplements, whether you're going to do it by the product, by the symptom, by the condition, by the lab marker. The program design part, I think, is where things can fall apart pretty quickly, because you might have like the perfect program in mind and design the perfect program, but then the patient can't do it or won't do it, right? And so, again, I mean, the problems are pretty obvious. So let me just state the problems that we're dealing with. Number one is that you get a GI map back and it's got one or more pathogens on it, one or more bugs, one or more markers, dysbiosis markers, candida markers, H. pylori, parasites. Something's wrong with the test, and maybe it's one or more of them, right? And then you've got a patient that's got a damaged gut, so they've got a leaky gut problem too. And then you're thinking, okay, I need to design a program to address all this. And I think the big variables are how much stuff can the person take at one time, how many products, right? And then how do you want to sequence the events that you're going to try to treat, right? And so there's variables on the patient side that are going to influence how you make this decision. One is how sick is the person, and the sicker that the person is, not GI sick, but just overall sick. If they have like an autoimmune disease and chronic fatigue and 3 other issues, and they're quite sick, then you may want to do a gentler program that's going to more prepare them for the GI treatment. That's rougher, right? Because it's rougher to get rid of bugs and it's more supportive to do the GI repair. So in a case that's complicated with a lot of, sickness, things going on, you may want to start with GI repair for 60 days and then go after the GI bugs. In an average person in my practice might be a 48-year-old female. She has hot flashes and night sweats, can't sleep, and is a little depressed and anxious, but is not chronically ill. Someone like that, you can get away with jumping right into the pathogen or GI, bug treatments and doing the leaky gut repair once the bugs are gone. Okay, and then there's other people maybe who are in between where you can start the killing of the GI bugs and start the leaky gut repair at the same time. So the sicker the person is, the earlier you want to put the GI repair in the program. Okay. And for some people who are quite ill, you may only do the GI repair for many, many months until they're ready then to start to treat the bugs. And the problem that I see the most commonly is that the GI infections are treated too early and there's not enough preparatory work done. However, if the person's in pretty good shape, you don't want to drag this on for 6 months, right? So there's some people who can handle, going right to the GI bug treatment. And then there's one other thing to throw out there before you look at the slide. Sorry, kind of going on here. But then there's another variable, which is that if you can test and correct the adrenal hormones and improve secretory IgA and reduce inflammation, then all the gut programs go much easier. Okay, so one way to address leaky gut is with a good, well-designed adrenal program. Just throw that out there. And we did a study on this. I did a study with the Mayo Clinic on this in 2016. It got published. And we had some really great results. We had like 9 of the patients in the study had H. pylori. 8 of them, we got rid of the H. pylori. I forget the total number of gut infections. It was like 20 something. We got rid of almost all the infections by taking this approach of using the lifestyle changes and adrenal programs and leaky gut repair as the warm up, right? And then going after the GI bugs when the system was in better shape, when the person was in better shape. Okay, so that's kind of the overall structure of what we want to talk about. So then in terms of the program design, we're thinking about how you're going to actually set this up, making sure that you talk about the goals, right? And you figure out the supplements and the follow-up, okay? That you take into account, number 2 here, the patient's needs. Some patients relax and feel better if you give them more products. Some people freak out and won't do it if you give them too many products. Some people want change to happen in a few days. Some people are much better or feel better about the whole process if there's really gradual changes and they do things one step at a time. Some people are super sensitive to supplements. Some people aren't. Some people can't swallow pills. Some people it's easy to swallow pills, right? Some people are cost conscious. Some people will feel better if they spend more. And so You got to figure this out through talking to the person before you design the program. Now, if you end up with, let's say, the extreme of this, and this happens all the time, right? Somebody who you figure out is going to feel better about the process if they take as many things as they can right away, and they're going to feel better about the process if they spend more money, right? There's people that are like this. Totally, it's a personality type. They just think that if they spend more money, the whole thing's going to be better. Those are the people that would buy like a first class seat, you know, from San Francisco to New York. And I'm thinking, wow, you just dropped like $3,000 on a ticket that you could have gotten for $300, but some people want to do that, right? And then other people are on the opposite end of the spectrum. They're sensitive to every supplement. They can't handle things. They want to go really gradually. So assessing all that stuff is an important part of what we're going to do with gut programs, right? Because there's multifaceted layers to the gut programs. You can't do all these things at the same time. And then third item here is the sequencing. Okay, clinical priorities, and then personalization related priorities. So by that I mean, like, you might think, I'm not going to be able to get this Giardia unless I get, the secretory IgA to be better and the gut lining to be less inflamed. And then there may be other like personal things that the person may be like, I have diarrhea 9 times a day. Can we just get rid of this Giardia now? I don't want to wait until the inflammation is better. Can we just get this thing cleared out now? So, the sequencing and how you do this, it can be related to those kinds of considerations as well. And then in terms of handling patient resistance, people are generally resistant to everything that we do. They don't want to spend money on labs or supplements, and sometimes they're even resistant to getting better in their own kind of unconscious, strange ways, right? So you want to make sure that you're addressing all the common concerns of the person during the consultation so you don't get a ton of emails. If you're getting a ton of emails, it means that your patient consultations aren't answering enough questions. Every email that you've ever gotten, just think about it, try to answer those questions during the paid consultation time so that you get 0 emails. You want to knock your emails down to like, 2 a week or something. If you're at 200 emails a week from patients, then you need to talk more during the consultation time. Answer those questions that you're getting via email before they even get asked, right? That's the key to the patient consultation experience. And then I don't get any emails hardly at all now because I studied this for like 20 years and I looked at all the questions that everyone would always ask. And then I structure my paid, I emphasize the word paid, consultation time answering those questions that I know that they're going to think about as soon as they get to their car and start to Google, H. pylori or something like that, right? So that's super helpful, and it'll cut down on your time. It's more efficient, less stressful for the patient as well. And then the end of program design is with maintenance and follow-up, so that you have a plan for what you're going to do when they're better, and you're not going to just kind of leave that to chance. Yep. Okay, so then I'm looking at protocol architecture, and I think of this as a design process. I don't know, like if you were a muralist and you painted murals for a living, so great. People can do that. It's like their job. They paint murals, right? They probably want to design the mural and kind of architect it and structure it before they just start painting freestyle. And so we think about the protocols. We're looking at the new patient intake experience, the lifestyle tasks that you're going to assign them to do, as well as the supplement programs, right? So it's an integration of these different things. And now, in terms of program setup, I know this is like very kind of practical nitty-gritty stuff, but this is often what kind of makes or breaks the business, Design the program, right, with the patient in the room. It avoids you having to bill for your extra time later. It avoids you making a ton of mistakes. So in the old days, I used to design programs at the end of the day when all the patients were gone. And I found that a lot of times people didn't like those programs. And now that I design every single program while I'm interacting with the patient, it makes a huge difference. It becomes their program that they get input on. And if they say, I don't really want to take that many supplements, then I'll say, oh, okay, well, let's do this in different stages. I always explain what each product is for when I write it down. And it makes a difference. It doesn't take more than 10 or 15 seconds per product. I'm going to recommend you do this glutamine powder. It's a powerful anti-inflammatory that heals the gut lining next, like that. just a one-liner on each product. So they don't remember any of this, but at least they'll just kind of, it'll register that there's a reason why you're giving them this thing. And if you don't explain it, then they're going to look it up and they're going to get all kinds of, kind of inaccurate representations of what they think is going on. I always write the products in the order of importance from the top down. So the top product is the most important product. So if they get to the office, my office staff, and they're like, I would love to do this program, but it's $786 for the first month, and I can't afford it. And they can only afford $400 worth of supplements. Then my staff will say, oh, well, that's fine. We'll just cut out the products at the bottom of the program here. They're not as important, and you can do those later. And we'll make sure you do the first 4 products on the list. So I always write products in top down, most important ones first for a lot of different reasons. Always recommend the length of time they're on the program. Reevaluation date is the most important thing on there, right? You want to make sure they come back. We set up a series of consults. So we have people book out 6 months. So, like, here's your new patient consult. Let's book out the next 6 months of all your visits. So make sure you can fit into Dr. Kalish's schedule. So in general, I see people about every 2 months. It's kind of typical. And then we always sell the supplement programs in a programmatic way, right? So if it's a 3-month anti-yeast program, we sell them the whole 3 months of the program all at one time. If it's a 6-month leaky gut repair program, we sell them the whole 6 months of the program all at one time. Why would you buy a month's worth of a 6-month program? It just doesn't make any sense. It's like buying a car and you didn't pay extra for the wheels or something. So like you got a car but it has no wheels, it won't go anywhere. Right? You don't want to buy part of a car. You don't want to buy part of a 6-month program. It's just not going to work. Right? It's not going to do anything. So we encourage people to buy either 3 or 6 month supplies or whatever the program length is. So they are invested in the whole process. And then just in general terms, effective programs, you want to plan them backwards, right? Starting with what the long-term results you're looking for are and what the long-term results the patient is looking for are. And, it's surprising what people really want to have happen in their lives. I mean, sometimes it's quite simple. But when I would design programs without understanding what the real goals of the patient was, they just didn't work as well. Right? And then, and thinking about, this is just like a general kind of philosophical slide here, like really, how many symptoms that your patients have can be linked back to GI issues? I've seen almost every single symptom I can imagine get better with GI treatments. It's everything from literally from toenail fungus to suicidal depression. I mean, it's not even a joke. That's like real. It's like not me being funny or a wise ass. Like I've really seen people's toenail fungus go away with the Candida program. And I've seen several people with extremely severe depression clear up when their microbiome got better. It happens. This is gut-brain connection, right? And then the other thing to think about, in addition to that thought, is like how many people have really severe digestive problems but have no digestive symptoms? How many people who are depressed and how many people with toenail fungus have really bad GI problems? Like a lot, right? So you want to test people whether they have GI problems or not, it's a pretty important kind of concept. And it's not always easy to get people to do GI tests. So I'm acknowledging that. But the more that you can have confidence in the fact that these GI problems can be present even without GI symptoms, and the more that you see crazy things like anxiety and depression and back pain going away with a GI treatment, the more you can confidently recommend that it's worth doing the testing, right? Okay, oops, sorry, hang on a second. Moved a little too fast there. Okay, so I also think about GI health as the heart and soul of functional medicine. I don't know, it just seems to be pretty important. So let's talk a little bit about integrating leaky gut protocols into the overall process. So here's the gut lining, right? And what we're worried about is when a gut lining topography or architecture is damaged and it's not working well. And then a couple of things happen, right? The villi or microvilli that stick up are blunted, okay, and they don't work as well. And then the intestinal crypts, those intestinal glands there, get deeper and deeper. And the whole structure is just getting kind of kafooey. So part of what we want to do then is make sure that we get an anti-inflammatory repair response happening and that we can start to address the leaky gut itself. Now, this is straight out of the Dr. Timmons playbook. Leaky gut can occur because you're emotionally stressed. One of the things we do when we're emotionally stressed is we make a lot of cortisol, and that makes us catabolic. And one of the things that happens when we're catabolic is we break down the gut lining, right? The very definition of stress and being catabolic is you're going to break down muscle tissue for fuel, and you're going to break down gut lining for energy, for fuel, right? And so the gut lining becomes leaky. That could happen just because your mother-in-law is staying with you for 2 weeks, right? It doesn't have to be anything more than intense emotional stress. You could also have leaky gut that's triggered from food allergies or food intolerances. You could have leaky gut that's triggered from a hormone imbalance. Any kind of chronic inflammatory issue could end up causing you to use up or chew up or destroy or damage portions of the gut lining. Okay. Antibiotics could trigger this. Certain prescriptions could trigger it. Non-prescription drugs like painkillers people take, like Advil and Tylenol and all that stuff. The list is pretty long. Just eating really bad food, could cause this whole problem to get started. And so once it's going, though, I like to think about the big 5 symptoms because these are the ones that I see every day in practice when people have messed up guts, right? They're fat, fatigued, depressed, have GI problems or female hormone imbalances. You could throw male hormones in there too, but most of my patients are women, so I don't talk about the male hormones much. So fat, fatigue, depressed, GI problems, or female hormone imbalances. You can have any one of these 5 because your gut's leaky. And I put GI problems 4th, right? So my list here goes fat, fatigue, depressed. We're not even to the GI problems yet. GI problems are 4th in my list of what problems occur when people have GI issues, right? GI symptoms are 4th on the list, and then female hormones. So for people that have GI problems, weight gain, fatigue, and depression happens a lot. GI problems happen somewhat, but you get more people with, who are fat, fatigued, and depressed that have GI imbalances than people who actually have GI imbalances that have GI symptoms, if that makes sense. So the GI symptoms are low on the list is the point. And that's why you should test. Anyone who's overweight, tired, or depressed should be tested. Okay. So here's again a little bit about leaky gut and all the things that can cause it. So here, I guess the most important thing and the question that I get asked the most is like, how do you stage this, right? When are you going to do the leaky gut treatment? And so in the sickest patients, you would start with leaky gut. You would do that for 2 months, and then you would go after whatever else you see on the test, the yeast or the H. pylori, et cetera. During those first 2 months, when you're repairing the leaky gut, you would use the glutamine type powders, any kind of anti-inflammatories like curcumin, maybe a little bit of liver support, and an adrenal program to go along with that. Okay, because those two together will really knock down the inflammation. It'll get the person out of that catabolic state. Because remember, if you're in a catabolic state and you're stressed and your HPA axis isn't working well, you're going to be chewing up the gut lining. So you want to stop that. The adrenal programs also help strengthen secretory IgA. So now the person's less inflamed, their immune system's working better, and when you get to the killing part, it goes really easily. Now, I get patients all the time who will come in and say, I had XYZ infection. This doctor tried to treat it. It didn't work. It's almost always not working because they didn't do enough preparatory work. Okay. Now, if the person's in really great shape and they're, I don't know, professional hockey player and they're about to go play hockey, and the season is starting in a month, you might not have 2 months to do all this stuff. In which case you're like, okay, let's just try to get the bugs right away. But if you have the time and you can take the time to do this, then things work a lot better if you start to reduce the inflammation first, okay? And then there's a progression of leaky gut, right? It gets worse and worse and worse. There's stages of leaky gut connected with all these different problems, and then the symptoms of leaky gut. So now, check this out, really. Symptoms of leaky gut. Like the first line there, autoimmune, chronic fatigue, depression, should have weight gain too. We're not even talking about gut symptoms yet. Now, the second line, gas, bloating, constipation, diarrhea, heartburn, abdominal pain, right? And then we're right back to non-GI symptoms, weight gain, inability to lose weight, joint pain, eczema. So I have a patient right now in my practice, a 3-year-old kid, a 3-year-old little boy, and he's got horrible eczema on his arms, on his legs, and on his neck, on the back of his neck. All we're doing is a GI map-based gut program, and his skin's getting better every month. The mom said 2 days ago, what did she say? She said the arms and the legs are completely gone, and the neck's like 75% better. Okay, it's not all the way there yet. That's the only complaint this little kid had was eczema, right? And it's all coming from his gut. Not that complicated, but you have to do the test. This is what Dr. Timmons just drilled into me 30 years ago. You got to do the lab. Got to do the lab. He was a lab guy. He ended up starting his own lab and ran that lab until the day he died. It's just, you got to do the testing. This is all about what we do. In my mind, functional medicine is lab testing. And I know we do lifestyle coaching too, but anybody can do lifestyle coaching. Any health coach, you don't need to be a doctor. You don't need to study functional medicine to be a good health coach. I'm not putting down health coaching. I'm saying that anyone can do that, who's a good people person. But what we do is special. What we do is these labs, and very few people are interested in these tests. So you really want to be, as Dr. Timmons would have said, you want to get the lab data. You want to be like the master of these labs, and that's really what kind of defines us, I think, as a profession. Now, you can have these triggers, right? Like a person could have come out of a surgery and have this problem. They could have, lifestyle factors could be all over the map and they're not doing things like that well. And there's lots of different reasons why this can get kicked off, right? But then this is where it's a chicken and egg kind of argument, okay? Where we have different types of bugs, yeast or bacteria or parasites, and we become susceptible to these infections when the adrenal glands burn out, when secretory IgA levels drop, right? Because of stress. When you're stressed and you're chewing up your gut lining in response to that stress, because you're catabolic, right? The definition of catabolic physiology is that you're breaking down things. So you break down your muscle tissue and you break down your gut lining. And there's tons of gut lining. It's a great thing for your body to break down because there's all kinds of energy just stored there, right? So if you're stressed and you're breaking down your gut lining and your secretory IgA is not that great, you're going to have problems with either acquiring these bugs or old bugs that have been there for a while flaring up. And that's why you want to start with an adrenal program to get the catabolic physiology under control, to just stop the process of leaky gut. Then you can give them, or at the same time, if you want, the glutamine powders and the curcumin and that kind of stuff to repair the leaky gut. But there's no point in repairing the leaky gut if they're stressed out of their minds and their adrenal glands are just frying them. Because every day they wake up stressed out of their minds with cortisol out of balance, they're chewing up their gut lining, and then you're dumping a bunch of glutamine in to try to repair it. It's like if you were, I don't know, running around lighting fires in the forest or something and then putting them out, but then you're just, lighting more and then putting them out. It's just like crazy town. That doesn't make any sense. So if you get the adrenals under control, and you can do that with DHEA and pregnenolone, these various supplements, right? And you get the stress response under control, and you give the GI repair stuff in the beginning. When you get to that 3-month mark, you've done all this stuff, preparatory stuff for 2 months. When you get to the 3-month mark, killing the Giardia, Crypto, H. pylori, candida is relatively easy. Without that prep work, you're just, creating so much extra work. Or you may end up have programs that don't work, which is even worse. So next item here is botanicals, and then how you're actually going to treat. So if you're thinking about, I guess there's a couple ways to think about it. One is that, let's say the person has an infection, a parasitic infection would be like sort of the classic one. Then by definition, just because of the infection, they're going to have a leaky gut. And so then the question becomes, am I going to try to get rid of the parasite first or heal the leaky gut first? And the easiest, most consistent way you get results is to work on the leaky gut and the adrenals for the first month or 2, and then go after the bug that you're trying to kill. It's much, much easier to get rid of these bugs if you've done that preparatory work. Then the question becomes, well, what are we going to do to kill this bug? Are we going to use herbal antimicrobials? Are we going to use antibiotics? How's that all going to play out? And so I had a patient yesterday. This guy had a horrible story. It's amazing. He's young. He's like 34 years old. He was hospitalized for this esophageal problem that kind of set him up. That was sort of the beginning of the end for him, And he's in a lot of pain still. All the GI doctors, 2 years later, can't figure out what's wrong. And they just kind of, I don't know, sent him out of the hospital or kicked him out of the hospital and said, you have, GERD, take some proton pump inhibitors. But that was kind of their way of saying we're really not sure what's going on, but we don't think it's a really bad medical problem because we scoped you every way we could and we didn't find anything. Anyways, I ran a GI map on this guy. He has H. pylori. This is like he's probably got the worst H. pylori infection that I've seen in 10 or 15 years. But I've seen this before, exactly like this. And so I was telling him that. He's like, yeah, I think you're right. Blah, 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 blah. And we agreed that he might want to use antibiotics because it's such a severe infection. He really doesn't want to because he's on antibiotics a lot as a kid. And so I said, look, we're going to try the antimicrobials first. We're going to do the 2-month adrenal program, the 2-month anti-inflammatory. As soon as you hit month 3, we're going to go after the H. pylori with the herbs. And if we're not really seeing some, significant benefit in the first couple months, let's be open to you seeing your primary care doc and getting some antibiotics. He was very happy with that plan. In fact, he said he's, kind of internet searched me for a long time and decided that I had the most rational way of treating bugs. And it's exactly what I'm talking about today. Patients really like this, because it makes sense and it works and it's thorough, It's not just this off-the-cuff thing. And I think if he had just tried to treat the H. pylori on day 1 without the preparatory work that we're going to do, the odds are, I don't know, maybe 50-50 it would work. I don't know. The odds are greatly reduced. That's going to work. One other thing to keep in mind too is anti-yeast programs to clear rebound yeast. So when patients have to take antibiotics, and it happens sometimes, right, there can be a rebound yeast overgrowth. And this happens also, and this happened in the mentorship class the other day. You're going to see this a lot if you're looking for it. Is let's say that you have a patient and they have Endolimex nano on their lab, and you get rid of the Endolimex nano. Does that mean everything's over? No. Oftentimes you'll see yeast flare up after the treatment of a parasite. Let's say they have blasto and you get rid of the blasto. It's likely and very possible, I don't know what the odds are, I've never seen anyone test, do a study on this, but you see this in practice all the time. As soon as that blasto is gone, very common to have a yeast flare up. I was taught by Dr. Timmons, I don't know if it's true or not, but it's just kind of his opinion on it, that you get rid of this one organism and there's all of a sudden a lot of empty space in the gut, and that either the good guys are going to come back or the yeast is going to proliferate. So you want to just keep in mind you often need to do anti-yeast programs as follow-up, whether the person does antibiotics or antimicrobial herbs. And those kind of people feel like the blasto is coming back or feel like the Giardia is coming back, but it's often just a yeast infection that's just flaring up, okay? And then in terms of programs, and we can look at some literal programs and some labs in a minute here, we have this anti-inflammatory healing phase, right, which includes the adrenal programs, the anti-inflammatory products like the glutamine powders, that kind of stuff. And then we segue into the getting rid of pathogens phase. And we'll talk about the order in which I recommend you get rid of pathogens. And then the repair and leaky gut recolonization. Okay. Now, for some people who are extraordinarily sick, you may want to spend several months doing leaky gut repair and anti-inflammatory stuff together before you go after the killing. Okay. And so the sicker the person is, the more preparatory work you want to do. And you may want to move step 3, repair the leaky gut, to be part of step 1 in people who have a lot going on symptom-wise. Okay. So again, getting rid of the bugs is sort of the midbrain, the midpoint in all this. And then make sure that you retest people to make sure that's gone. So here are the general rules. You test for the bugs, you eliminate, use probiotics typically after the bad guys are gone, replace the healthy bacteria earlier if you have to. Like for my H. pylori guy I was talking about, I put him on probiotics right away because he's not doing well. And even though I usually recommend the probiotics after all the bad guys are gone, this guy just didn't have the luxury of waiting, right? And then make sure that you retest for all this stuff as well. Now, there's a whole bunch of common problems. And just so you know, then there's a few more slides here. And then we're going to talk about, I'll show you some sample labs, all right? And then we'll have time for questions if you guys have any questions. So common problems encountered: stool testing and organic acids, missed yeast overgrowth. So even the best lab companies can't find everything, right? So once in a while, you might need to treat even if there's not positive test results. Just throwing that out there as an option, you know? How often do I do that? Maybe once every year or two, meaning the vast majority of time, the testing is going to nail it. You may want to do further GI testing, right? With the DNA markers. That's kind of hint, hint, that's the GI map test. So sometimes you'll find, you know, a non-PCR based test misses things, in which case I'll suggest that, you know, so a patient comes in, they did a non-PCR based test, and everything looks normal. I'll suggest that they do a GI map. It's a little more advanced DNA-based PCR testing. We might find something. And then there's also patients that have SIBO, and there's patients that think they have SIBO. It's kind of two different groups. Probably a lot more people think they have SIBO than have SIBO. But anyways, sometimes you need to refer out for SIBO testing, you know, as an additional step. And then I just have remember the gallbladder in there as a one-liner because it's the thing that trips me up the most. And I see this with a lot of practitioners that I've worked with as well, not just me, is that gallbladder problems can mimic so much, you know, because when the gallbladder is not working well, you're going to get a proliferation of bacteria in the small intestine. It's more than just not absorbing fat, right? You can have pretty severe small intestinal bacterial overgrowth just as a result of gallbladder dysfunction. So always remember to check the gallbladder or give them some gallbladder support if you're wondering if that's a problem, okay? So you don't miss that. So again, as the gut lining gets used up or damaged, people start to experience all kinds of problems, right? It's not just with the gut. They may get depressed because the serotonin's getting screwed up, or they may have immune problems because the immunoglobulins aren't working so well. So you can have huge ranges of symptoms as the gut lining is being damaged. It's huge. And then I'm a big advocate of patient communication skills development, you know. And so when I have patients I'm trying to describe this to, I really try to look at the lab, show the test to the person, and make sure that I'm addressing the findings on the lab and explaining the findings in kind of clear language so they can understand what's going on. So for example, if their SIG-A levels are low, I'll talk about how stress can impact secretory IgA and how cortisol regulates the production of secretory IgA and how that, when it's a problem, weakens the immune response, right? And I'll talk about food reactions in the same way and talk about GI tract infections so that you should have some really kind of loose scripts prepared where you're really able to communicate exactly what you want based on the actual lab, okay? All right, so I've got some sample labs set aside here. So now, taking all that into account, let's look a little bit at sequencing of things. And let's just scan through the lab first, and then we can look at individual labs also. So, Dr. Timmons taught me this order. I have followed this order for 30 years. It works so well. I've never had the courage to change it. So, when I'm gonna look at this lab in the order in which I look at it, which is not in the order in which the pages occur. Okay, just so you know, because this is the order in which I need to know things in my brain. So what do? The first thing I do is go to the top of page 2 and look at the H. pylori markers. It's the first thing I do for every one of these labs. 30 years of habit here, okay? Now, Diagnostic Solutions hasn't been around for 30 years, so there's other testing companies in the past, but it's always the same thing. I look at the H. pylori section first. Why? Because if that's high, that's the first thing I'm going to treat. So when there's multiple infections, Timmons would always say, you just do H. pylori first. Why? I don't know why he said that. It's your stomach, because it's your stomach. It's highest up in the gut lining, right? If you don't get that cleared up, nothing downstream is going to work. You know, it's just a must clear problem. You got to deal with it first. You know, stomach acid, related issues, you're not breaking your food down well in your stomach, then how are you going to get the person better? I mean, this is a top priority. So if H. pylori is present, and this one it just randomly happens to be, then that would be the thing that I treat first in a multiple bug situation, okay? But before you treat the H. pylori, you do the adrenal program, then you do the H. pylori, right? Okay, so then, and we can do, if we have time, then we can do some actual protocols. Then the second thing I look at, sorry, is up here. I know this is a little crazy town, but this is the way I do it. Parasitic pathogens, that's item number 2, because that's the second thing I'm going to treat if they're present. And it's like, in this case, none of them. But let's say Giardia was present. The person has H. pylori and Giardia. H. pylori first, give them a break for a few weeks, then go after the Giardia. Okay? And then I look at the other parasite section, which is way down here, where it says parasites, right? Parasites or protozoa. So then I would look at this next. Oh, look, Dientamoeba fragilis. Ouch. Okay, so now we have D. fragilis and we have H. pylori. What do you do first? H. pylori first, give them a week or 2 break, then go after the D. fragilis. I would never try to do those 2 at the same time. I have tried to do them at the same time, and it always goes poorly. In fact, my old line on this, if you've heard my old lectures, was I try this, once or twice a year and it never works. I don't even try it anymore. I'm getting so old about this stuff. It's like, I wouldn't even try it. You guys could try it. I tried it once or twice a year for 20 years. You guys can try it. It never works, but try it for 20 years and then you'll get to this conclusion. Treat the H. pylori first, give them a week or 2 break, then go after the parasite second. Okay. Now, and remember, parasites are in two sections here. They're under here. They're here where it says parasites, protozoa, blasto, chalaomastix, Dientamoeba fragilis, Centamoeba coli, etc. Right? These guys. And then the other place they show up is up here. So you got to look at both these areas. It's on page 1. That's the big 3 they have here: crypto, ehisto, and giardia. So these are parasitic pathogens. The other ones are just parasites. These are considered, the parasitic pathogens are considered more serious, right? Okay, and then the third thing I'm going to look at, so we do H. pylori, we look for all the parasites, then we're going to look for dysbiosis in yeast. Okay, so dysbiosis is conveniently all kind of located right here. Opportunistic bacteria, 3 of them present, so a person has dysbiosis. And then under yeast, it's normal. So you can see where this is heading, right? I look at it in the order in which I'm going to treat. So if H. pylori is present, treat that first. If any of those parasites are present, either crypto, giardia, ehisto, or the other section of parasites, treat that second. And if there's a yeast or fungal overgrowth or a dysbiosis, treat that third. Okay? So if they have all 3 of these, so they H. pylori, giardia, and a really bad candida overgrowth, I'll go for the H. pylori first, give them a week or 2 break, go for the parasite second, the giardia second, give them a week or 2 break, and then go after the yeast. Okay, and there's a lot of sophisticated reasons why Timmons ordered it in this way, based on his decades of experience. And Timmons ran these huge clinics, one in West Virginia, one in Mexico. These naturopaths were busy, man. They were treating hundreds of patients a year, hundreds and hundreds and hundreds. It was a huge clinic. He had a huge clinic in Southern California too, near San Diego, that he ran. So anyways, this was based on like serious, I'm in the trenches dealing with this experience, okay? It wasn't just like, oh, wake up one morning, we're going to start doing it this way. So I was lucky enough just to kind of capture that information. And so when I'm looking at this with a patient, this is the order in which I would do it, right? I would show them the H. pylori results first, then I would look at the parasite results second, and then I would look at the dysbiosis and yeast markers third, okay? And then at the end, when you've done all that stuff, then you can look at the intestinal health markers. Now, I know that's totally out of sequence, but should I review that one more time? I don't know if I'm confusing everyone or not, but let's look at a different lab maybe. I can show you one more time. I know it's out of sequence and it's a little awkward, but this is just the way that it works in my mind, and then that's the way I'm going to sequence the treatment. So it's easier than doing it out of sequence. So what do you do first? You go to the H. pylori page first, which is page 2. And let's see. Uh-oh. Oh, here it is. So this pagination is a little different. But anyways, H. pylori is negative. Okay, but now we do second, we look for parasites. Giardia is positive in this case. So what would we treat first? Giardia would be first. As well, if H. pylori isn't normal, then we're going to treat parasites next. And then third would be autoimmune opportunistic bacteria. There's a few there. Now there's another parasite, Endolamics nana, and a yeast overgrowth. Okay, so for this person, it would be the Giardia and the Endolamics nana first. Hopefully you can do that with the same medication or herbal program. Once that's done, a week or two break, and then going after the yeast and the dysbiotic bacteria. Okay. And let's look at one more example here while we're on a roll. And then I want to show you some protocols and we'll go for questions. Oh, C. difficile. We didn't talk about that. C. difficile falls. Oh gosh, C. difficile doesn't fit with my system. Ooh, boy, I wish I hadn't pulled this one up. Sorry. So C. difficile, it depends. Tim has never taught me an exact role for C. difficile. C. difficile, it depends on symptoms. I hate to say that, but oftentimes you treat C. difficile first. Sometimes you can get away with treating it last. It depends on what else is present. Okay? But sometimes there's an immediacy with C. difficile and you treat it first. So if I was going to just do one, kind of fixed rule, I'd probably say treat C. difficile first. That's probably the easiest way to look at it. Okay, that's not always the case, but often the case.
We do have a couple of questions if you would like to answer them.
Thanks.
Okay, sure. So the first question we have asks, can you talk more about elevated secretory IgA? Why is it elevated and what to do about it?
So when secretory IgA is high, it implies that there is an infection present, right? And that you want to treat the infection to lower the SIG-A. And you don't necessarily need to use SIG-A lowering products, right? It's gonna kind of take care of itself if you clear the infection up.
Great, thank you. The other question we have asks, how long should we wait to retest with the GI map after a patient has taken antimicrobials?
So the rule of thumb is 2 months or 60 days after either antibiotics or antimicrobials are done, you'd want to retest.
Great, thank you. The next question asks, does the dysbiosis/imbalanced microbiomes also affect thyroid function, thus presenting symptom number 6 from your chart? If so, what is best to treat this? For example, hypothyroidism.
Yeah, so when we think about thyroid in general, if the body's inflamed, you're interfering with the conversion of the thyroid hormones, right? So whatever causes inflammation can potentially cause a thyroid problem. And when you're thinking about it from a functional medicine perspective, one of the major potential sources of inflammation would be gut problems. So the more severe the gut problem is, the more likely the person could develop a thyroid problem, especially if they have a tendency in that direction anyways. And it's the same with adrenal issues. The more inflamed that the gut is from gut-related infections, et cetera, or food reactions or bad diet or whatever is inflaming the gut, the more likely they'll have an adrenal problem. It doesn't mean you don't treat the other things, right? So you still have to treat thyroid and adrenals or treat whatever the gut inflammation is causing. But the underlying problem, the gut problem, has to be dealt with too.
Great, thank you. The next question asks, if H. pylori is not elevated, what else could be the cause of GERD?
Most common thing I see is that they have a subclinical hiatal hernia. The stomach lining is just pulled up above the diaphragm. So we refer out a lot for visceral manipulation to pull the stomach lining back down, and then it's mysteriously and instantly gone. Maybe it takes 3 treatments or 4 treatments or something. But so sometimes it's just a mechanical problem. In other cases, it's other bugs. Like I've seen it with yeast frequently. I've seen that problem with various parasites also, not just with H. pylori.
Okay, great, thank you. The next question asks, besides zonulin, what else represents a leaky gut?
Well, Timmons would say, so I'll channel Dr. Timmons for a little while. If your adrenals are in really bad shape, you probably have a leaky gut. If you have any one of these infections that we're talking about, you probably have a leaky gut. If you have dysbiosis, you have a leaky gut. If you're eating the standard American diet, you for sure have a leaky gut. If you're, so the leaky gut part has become kind of the standard, kind of baseline way that Americans are living. I would say almost everybody that's obese has a leaky gut. You kind of have to, right? In order to get fat in the first place, you have to have some gut damage. So it's almost all of our patients to a certain extent. The other ways you can track it are with things like secretory IgA. You can track it by, again, looking at the infections. You can track it by looking at any of the inflammatory markers. Those are all ways you can kind of see. And you can see it on more other testing too. Like you can see, like if you see I see this a lot of times, if you're doing amino acid testing, you see like 15 amino acids that are low, and the person eats protein with every meal. You're like, oh, probably you're not absorbing this so well, and probably you have a leaky gut. So we see leaky gut almost everywhere we look, really.
Okay, great. Thank you. The next question asks, do you treat H. pylori always when it's present, even if no virulence markers are present?
Yeah, so this is my personal opinion, and I wouldn't take it too seriously, but absolutely yes. I mean, I have a strong personal opinion on this, so I'm trying to, not trying to talk anyone into doing what I do, but I have treated personally over 1,000, maybe close to 2,000 H. pylori cases. In my mentorship class, we get, I don't even know, maybe another 100 or 200 H. pylori cases a year. I mean, I'm seeing a lot of H. pylori labs, and at least this talk from my own personal experience, forget about my students. Every single time I've treated H. pylori, I've been happy I did it, and the patient has been happy I did it. So I know that you can have commensal forms of H. pylori. I know it can be protective for the gut in some people, but for reasons beyond my understanding, I don't attract those patients at all. And H. pylori is my absolute favorite thing to kill, and I would kill it any chance I got, at least among my patient base. If you have a different group of people coming in, it may be different, and the research kind of doesn't line up with my personal experience in that regard. And that may be because I treat really sick people every day, and I don't get really easy cases, so I have maybe a distorted view of it. But I would feel, this is my old rule. I made this rule up like 25 years ago, just for no particular reason. I was just sitting around one day and I just thought, you know what, this is a new rule. And I told this rule to every patient for a long time, which is that one of my basic rules for all my patients is that you should be infection-free. That seems very reasonable, And how are we going to know that that's happening? Well, we're going to do a GI map test on you. But Dr. Kalish, I can't get pregnant. I don't have any digestive symptoms. I'm like, okay, well, if you have a gut infection and you have malabsorption, it's going to throw off your hormones, right? And so that's my bottom line rule still, that all my patients should be infection-free. We have the lab testing technology. We have the ability to get rid of these infections. It seems like negligence to just let people walk around with a whole bunch of GI infections and not even know about it.
Great, thank you so much. So that is all the questions that we have time for today. So thank you for joining us today, and thank you, Dr. Kalish, for a great presentation.
Appreciate it. Take care now.